I want to thank everybody for coming today to our, I think what is our last population spotlight for the academic year. We have our guest is Dr. Glorisa Canino from the University of Puerto Rico. She is a professor of pediatrics at the School of Medicine at the University of Puerto Rico. And she also directs the Behavioral Sciences Research Institute, also at the School of Medicine. Dr. Canino has been doing research for well over 30 decades. I won't say how long, but...
30 decades? That's 300 years.
For over 3 decades, well over 30 years. She has been continuously funded by the National Institutes of Health and other organizations for her research on the island as well as on the mainland. Where she's focused her work primarily in the area of psychiatric epidemiology, but also in mental health services research and policy, where she's focused on children and families. She has she's been involved in a number of longitudinal cohort studies, where she's followed generations of Puerto Rican families. And she's also been a mentor to a number of young Latino academicians, including myself and a number of other people throughout the United States who've gone on to have successful academic careers and get tenure and all that good stuff. And she currently has, I think, 4 R01s, 4 NIH grants, and she's extremely productive, over 300 publications. I can go on and talk about Dr. Canino. She's amazing. And so today she's going to talk about some psychiatric comparisons between mainland and island Puerto Ricans, and also put it into the context of the Hurricane Maria, which was a natural disaster that happened last September 2017, and I'm sure you guys are all eager to hear about. So, Dr. Canino.
Well, important. Turn the microphone on. Okay. I wanted to say that I am delighted to be here. I studied here at Temple. I got my Ph.D. in psychology at Temple many years ago and loved Philadelphia. Actually, I went back to the island because I had to go back. But this was a place that I really, really like and enjoyed, you know. And so I'm so glad to come back, and I'm honored to be here in a place that I lived for so many years. And then I also want to tell you that at the time I was here, which was in the 70s, you weren't even born, you know, Drexel was not this university. It was not, you know, considered such a great university. And now I come, and here I see this incredibly effervescent, how is that in English? Is it correct? Effervescent university with so many really top assistant professors, you know, and top people that I consider really, really talented, and a university with people with really emphasis on wanting to grow in research, wanting to grow in everything, you know. So it is so refreshing and so nice to be here, and I see this university as a very promising university. Already is, you know, doing fantastic. So it is for me a great honor to be here. So with that presentation, I want to just present to you my humble research, you know, in a small island with a university that probably has a very low standing, but there are people who, in spite of that, you know, are able to do the work that I do, mostly collaborating with people outside of the island, because we don't have the critical mass that you guys are developing right now. But critical masses can be constructed, you know, not necessarily in the same physical space, but electronically and with airplanes. Think of that. Okay, so what I'm going to be doing today is comparing the results of a study that was done in Puerto Rico 2 years ago, And in the United States, 10 years ago, 2014, 13 years actually, and 2004, I mean, and in, which are psychiatric epidemiology studies, and another one that was done, NLAS was called, National Latino Asian American Study, of the Latino and Asian population of the United States, also in 2004 to 2006. Ours was done 10 years or 13 years later. But these, they have in common that their 3 studies are psychiatric epidemiology studies. But before I start, I want to present to you a little bit about our island, okay? As you know, we are a very small island, 100, miles wide times 30, long times 33 wide. So we're tiny. But we have one of the highest densities, population densities of the world, okay? And so we became a territory of the United States in 1898 as part of the Spanish-American War, and we still are a territory of the United States, even though some people think that we are a commonwealth or that we're independent, but we are a territory. Right now, we are being almost governed by a fiscal board. I don't know if you're here about it, a fiscal board that was appointed by Congress to determine and the future of our economics in the island. So we continue being a territory. So to give you an idea of our, GDP per capita in the island, in the U.S. it's 57,000, Puerto Rico is 29,000, and the poorest of your states is 32,000. We have very high criminality rates. It's becoming higher because, as you well know, when poverty increases, criminality also increases, So our criminality rates have increased. I don't put it there because I cannot trust what we get from the police department. But as you all know, the people who are in public health, when you hear what an epidemic is when you start seeing people in your small network who have been sick of that epidemic. Well, here, we all have friends and families who have been attacked, or robbed, okay? So we know that we have high criminality rates. We have 44% of our population below the poverty level. We have 56% of the population out of the labor force. And the reason why I bring you this is because if you look at the unemployment statistics, it's not that bad, 12%, But unemployment has nothing to do with reality, because in a country where people can't find a job, after a number of years, they stop looking for a job. And unemployment is calculated by those who are seeking a job. So the important statistic in poor countries is not the unemployment rate, it's the people who are out of the labor force. And as you can see, we have more than half of our population out of the labor force, and not because they don't want to work, but because there's no work, okay? So of course, whenever you have a poor country with such a high percentage of unemployment, of people out of the labor force, you know that there has to be an underground economy. And of course, we have a huge underground economy with all that it means, that I'm not going to get into that at this point. So, our first psychiatric epidemiology study was in 1985. And it was some years after the epidemiological catchment area study. And this was a study that was done in the States, a psychiatric epidemiology study that was done in the States in 3 major cities, all right? And it was for the first time that it was done in the States with an instrument that was created for for being able to diagnose a psychiatric disorder according to the psychiatric nosology with a computerized instrument. Because population-based studies are done with large samples. And before this instrument that was called the diagnostic interview schedule, you used to be able to, you had to give a psychiatric disorder with a clinician. Now, you can't hire clinicians, it's too costly to do a population-based study of 3,000 people. Just don't have that kind of money. So this was the first time that this lady called Lee Robbins developed this instrument that you could come up with a psychiatric diagnosis of a person with a computerized interview that could come up with a disorder with a number of algorithms based on the psychiatric nosology. Since then, psychiatric epidemiology studies based on the present nosology, psychiatric nosology, can be done, thanks to this. Okay, so in '85, we did a study, the first psychiatric epidemiology study of the island. And we decided to compare this study, actually we did it because we wanted to compare, and we got money, because the US wanted to be able to compare their results with another culture. And so we put in an application, got funded, and did our study, and then we compared the rates the US had gotten with the same instrument, the same methods. Actually, I had Lee Robbins, the originator, as a consultant of our study, and John Helzer. Okay, so our hypothesis was that due to this high adversity and stressor that the island was experiencing, we would get, higher rates than the US, okay? This is what we thought. I mean, because we all knew, Darwin had published and many other people had published how poverty and adversities and unemployment were related to high rates of psychiatric disorders. It placed people at risk for a disorder. So since we had so many risk factors, I was convinced we were going to have high rates. Well, wrong, okay? So, wrong, because we didn't at that time. We didn't have higher rates. In fact, when we, at that time, so many years ago, when we compared our rates after, controlling for socio-demographic differences, our rates were lower than the US rates, in spite of all that. So now, 30-some years later, we get to do another study. This time, instead of based on DSM-3, we're doing it based on DSM-4, which is the latest psychiatric epidemiology. Okay, no, the latest is DSM-5, but we're doing it on DSM-4 because we don't have an instrument that is computerized for measuring psychiatric disorders based on DSM-4, on DSM-5, which is the latest nosology. Okay, but the differences in nosology between 4 and 5 are not that great for many of the disorders we're interested. Okay, so there are 3 main aims, is to compare our rates in the island with those of the US population at large that was done in 2004 by Ron Kessler, and with those of the Puerto Rican population of the National Latino and Asian Study, right? That was done by Margarita Alegria, published in 2008, but done in 2004, 2005, 2006. And then to examine the role of social and family support in protecting our population from psychiatric disorders, because that's what we hypothesized in 1987. It was so counterintuitive that we would have the same rates as the US when we had so many risks compared to the US that we figured it must be that we have a lot of supportive mechanisms that make our population resilient in the face of adversity, okay? And so we hypothesized it was due to what has been typical of most Latino societies, which is a very neat family support and family networks, extended high networks, of family and friends, and that these networks and family support was the one that was, was mainly the contributing to our rates of disorders. We didn't measure this in 1984, because we were not expecting what we found. So now we measured it. Okay, so that's the difference. Okay, so these were our hypotheses. Island Puerto Ricans, vs those of the US, will have similar rates than the ones that we found, just like we found 30 years ago. Okay, because our system still, our population still continues to have very high family support. Okay? So when we compare US Puerto Ricans with island Puerto Ricans, we hypothesized that US Puerto Ricans would have higher rates than us. Why? Because US Puerto Ricans are a minority. We are, in our island, a majority. Okay? Obviously, minorities in this country, and not only in this country, over the world, minorities are always discriminated against and have more difficulty, have more problems making it, because of the discrimination and poverty and whatever, or everything Downward social mobility, disruption in social and family. You obviously, when you migrate, and we don't immigrate, we migrate because we're US citizens, by the way. Anyhow, when we migrate, we lose our, family and social support that we had in the island. So we are at a greater risk. Like every migration or immigration to this country. So we also, hypothesized that social support was an important protective factor against the risk. Okay, so these are the methods we used, similar to the methods of most psychiatric epi studies. By the way, they don't get to be done anymore because the NIMH or NIH is not giving money for this kind of study. And I would have never had this study if it weren't because the mental health commissioner, and these are the fortuitous things that happen to researchers, needed Medicaid money and the block grant, and the US, from which we get the money for the block grant, said, well, you have to tell me how many people are in need of services who are not getting the services. And so for that, we need it island-wide, and otherwise we won't give you the money. So they came to me and they said, we need a study that gives us, a need assessment that gives us this information. And we have some money from Medicaid to give you. And I said, well, it's going to cost such and such. And they said, well, we don't have that kind of money. And I said, well, I can do it, but I will not have that much precision, if the n has to be smaller then. And I said, that means I'll have a percentage, this kind of percentage of error. And they said, oh, we don't want that kind of error. I said, well, then you have to give me more money. Well, anyhow, they gave me the money. So they gave me the money that no institute would have given me the money for because it's out of vogue, it's out of vogue. And you have to be in vogue, so I would have never done this if it weren't because of Medicaid. Anyhow, here it is. So what I said to you before, I'm going to be comparing the 3 surveys. Now, it's important to know that there's almost a decade of difference in surveys. And there are some psychiatric disorders that we all know, the people who have done this kind of work before, that don't tend to change with time unless there's a period effect, meaning that there is a big change in that country that have produced stress, for example, a war or a major disaster. Now, this study, a major disaster like what we got in Maria, this study was done 2 years before Maria, like Alex said. So it is the perfect study to have done, because now when Alex and I write this proposal, Alex is going to be the PI, and we're going to do this study following this cohort with 3,000 people, island-wide representative sample, measurement psychiatric disorders with the same instrument, which is the only one right now, the CIDI, and we're going to be able to tell before, when there was no major stressor in the island, no hurricane, after the hurricane 2 years later, okay? That's the proposal. We're hoping we'll get it. Very few people have that kind of luck of being able to have prior, health information, particularly psychiatric, information before a disaster. Because what happens with disasters is people, whatever you ask them, that happened to them was related to the disaster. It's called telescoping, which means, if you ask me if I have trouble sleeping, and since when? Oh, since the disaster, since the disaster. And in reality, it could have been that they had that sleeping problem, much before that. But you tend to attribute most of what happens negatively to you to that event. And so it's not a good idea. You really need to be able, in order to find out what are the effects of a disaster, it's crucial that you have prior information. Okay, so I just wanted to tell you that this instrument, the CIDI, which is the only one we can do, is the only one translated into Spanish, the only one that can be used in large samples that will give you a psychiatric disorder, and the only one that has decent, concordance with clinical diagnosis, not for anxiety disorders, not good. But at least for substance use disorder and depression, it's good. Yeah.
Can you talk a little bit about the validation of this to be in Spanish for the Puerto Rican market?
Yeah. Well, after we translated the instrument to Spanish, we have a professional translator do the first translation. Then we have, a bilingual team. The bilingual team is a number of experts, meaning people who know the instrument well, who know about psychiatric disorders, and who are completely bilingual, English and Spanish. And then we go, and we do, after that first translation, we then meet the bilingual team and go item by item by item to make sure that every question is going to be understood by a population that has a reading level maximum of 6th grade, okay? Because even though we have very high rates of high school graduation, that does not mean that they are at a high school level in terms of reading. It means that a lot of our students are passed, not because they met the criteria for passing grade, but they're passed. So we know that instruments need to not be at a higher reading level than 6th grade. And what happens when you're trying to, adapt an instrument to another culture that is a poor country like ours. Ours is supposed to be a middle-income country, but it feels more like a low-income country in reality, given many of our statistics, So that is the most difficult part, because in the States, the instruments are done in such a way that most of them require a reading level higher than 8th grade, And so lowering the difficulty of reading and understanding of an instrument is not only the translation, but most important, the comprehension of the person who's taking the instrument. And the person is not reading it, we are reading it to them, but they have to be able to understand the level of abstraction that it's needed, okay? So that was part of what we do. And then the other, of course, then we back translate into English what we first worked with, this bilingual committee. We back translate it, make sure that in our translation we didn't change the intent of the question, okay? And it's never literal. It could be very different when you translate it back to the English, but the important thing is that it's measuring the same thing, okay? So, anything else you want to add?
No, I was just going to give an example, like feeling blue.
Oh, yeah, feeling blue. Obviously, you're going to say, sintiéndose azul, No, That's why good instruments do not use idiomatic expressions, because you cannot change, you cannot translate idiomatic expressions. No way. So we would use, we would use a translation that is not an idiomatic expression, but that portrays the meaning of feeling blue. That's why the bilingual committee has to know English very well, because in order to translate, it cannot be literal translation. It has to be translation of the construct, particularly if the instrument, like this one, used to have that kind of whatever. Okay, done for the US and the US only. Okay.
Since then, is there an adequate instrument to use for anxiety disorders or after?
Well, there is no other instrument, so it's not like you have a choice, for big psychiatric epidemiology studies. There are other instruments that you can use in small samples because they require clinicians. But an instrument that does not require a clinician, that, a lay interviewer with just 2 years of, university, can be trained to give, this is the only one nowadays based on the latest, not the latest, but the one before the latest psychiatric, nosology. So you don't really have a choice. We have to give this one. But what we have to say, and not always everybody says it, but we say it, is that, caution has to be exerted with and I'm telling you right now, when you look at the rates of anxiety, caution has to be exerted with the rates of these disorders, because their validity is not as good. It's not adequate, okay? Sometimes you just don't have any choice. Okay, so as you could see, our response rates are higher than the other two. The other two is a kind of response rate that usually you get in population-based studies in the U.S. It's a different story. People in Puerto Rico are much friendlier. There's less research going on. People open the door to people with a School of Medicine badge. So we get better. Through history, we've gotten better. But through history also, we have gotten lower response rates than when we started. When we started many years ago, our response rates were 95% of those who were eligible, completed the interview. And now it's gone down to 83.8% now. In our first study, it was 95. So you can imagine what happens with time. People become much more suspicious of opening the door. Criminality has gone up, Other researchers have come in and they have not liked the experience they had. So the US, has a kind of research of response rates that are similarly big, developed, big societies, urban development, anyhow. So I want to explain to you a little bit more about the social support measure we use. It's the same support measure that was used by Kessler in the NCSR study and by Maggie Alegria in the NLAS study. It's a short scale. Obviously, you want to get short scales, for when you're, doing such big samples. This one asks, how often do you talk on the phone or get together with family or relatives who do not live with you? And then it's a scale that goes from 1 to almost every day to 5, less than once a month. And the other question is, how much can you rely on relatives who do not live with you for help if you need to talk about worries, And again, it goes from 1 to 4, from a lot to not at all. And then there are 2 other items related to the size of the network of family and the size of the network, of friends that they do, that helps them. Okay. So now I'm going to give you a summary of the results, okay? I don't want to bore you with these huge tables. So what I did, instead of presenting you these huge tables, is to summarize the results, And let's look at the demographics, The educational level, surprisingly, island Puerto Ricans completed high school more than the two US groups. We had more people in our sample that had high school. Again, but that doesn't mean too much, as I said to you before. The fact that they completed high school doesn't mean that they are read or, okay. So we also had a modal educational level of some college or vocational school, while for the other two sides it was completion at high school. So there were more, that in the island who would go after for vocational schooling. And then in terms of income, obviously, Puerto Ricans were more likely to have lower monthly income at both extremes, below $1,000 a month and above $3,000. So, US, one of the good things of the US is that you don't have the pyramid that we have in Latin and South America, and in Puerto Rico, it's becoming even worse, that pyramid, Small group of people with a lot of money, big group of people with very little money. That's what's happening in the island, which is not what you have. You have a big middle class. So you have more like a square. You don't have a pyramid. Let's hope you never do. Okay, so let's go. Unemployed, island Puerto Rican, and out of the labor force, obviously, much more likely, significantly. All of these are significant results in terms of the differences between the samples. So when we look at the overall rate of disorder, that is, how many people in Puerto Rico had, an overall rate of all disorders, versus the U.S. population and versus the U.S. Puerto Rican population. And as you can see, let me see if I can, there is really no big difference between these three. Overall prevalence rates, almost the same. Oh, sure. Well, let's hope I don't freeze,
Okay,
But
back on if you need it, but it's rubbing on the mic.
if it gets below 75, I start getting very cold, Okay. Anyhow, so this was what we had hypothesized. When we look at the rates, even though we had so much higher, adversity, our rates are going to be similar. Sure enough, that's what happened, And so, although this was true for overall, when we start analyzing the specific disorders, we find differences, okay? No differences were found either in any anxiety or depressive disorders across sites, except for the substance use disorders. Now, I imagine that those of you who have studied, substance use disorders know, as you can see, Puerto Rico 7.8, US population 4.6, US Puerto Ricans 3.3. Now, those of you who have studied substance use disorders know that contrary to the other disorders that usually do not change with time, substance use disorders will change with time depending on a great part on the availability of the drug. Obviously, those countries where the drug is very expensive, like in some of the Asian countries, or in countries like where also in the Asian countries, where, for example, alcohol produces to much part of the population a flushing, becomes a negative, reinforcer. Those populations have very low rates of substance use disorders, First, because it's hard to get the drug because it's very expensive, or the alcohol, or second, because it's producing a negative health effect. Okay. Now, Puerto Rico, you have to remember, this study was done 13 years after those other two disorders. When we first did our study in 1984, our prevalence rate, lifetime, was 1.4% of the population, okay? Last 12 years, it didn't even get to 1%. Everybody thought, nah, that's not possible. There is so much, criminality in the island, and all the police said this is drug-related. I even ended up talking to the head of the FBI, who confirmed what I already thought was the reason, you know. Oh, and you also have such high rates of HIV. Well, I found out at that time, you know, with the FBI director, first, that he said, you're right, Glorisa. The problem is not drug addiction. The problem with this island is that Puerto Rico is a hub for the rest of the US and Europe, you know, of drugs, of trafficking of drugs. The drugs from Latin America come first to Puerto Rico, and from Puerto Rico, it exports it out there. And that's why we have such high criminality rates. We have one of the highest homicide rates of the US, only secondary to Washington, D.C., okay? We have very high rates of homicides related to drug trafficking, not to drug addiction. Okay, that was before. Now, you know, why? I'm still killing myself trying to explain this, you know. But one of the things that is clear, I mean, I've been reading a lot, all these, you know, studies that, you know, Bridget Grant and Deborah Hassin have been writing on alcoholism. And they have been comparing the rates of alcoholism in the US 10 years ago to now, you know, the last 2 years. And what they have observed in, you know, in alcohol rates is that there has been a dramatic increase in alcohol rates from 10 years ago. Now I asked them, have you done the same for drugs? You know, because I keep looking everywhere for your articles on drugs. Have you observed the same? And the only thing I have seen is you, Debbie, you know, that showed that the rates of marijuana disorder, you know, are 3 to 4 times greater than they were, you know, 10 years ago. But what about illicit drugs, you know? She said, you know, Glorisa, you're right. I don't know why we haven't written it. And I said to her, well, can you give me that data? And she said, well, I have to analyze it, you know. So right now, I can tell you that for marijuana disorder, it has increased dramatically from the last decade, okay? But it is also true that this country has relaxed its laws and attitudes towards marijuana. And you have states in which marijuana is used, you know, and is legal, commercial, I mean, for just having it. It doesn't have to be medical marijuana. And so the attitudes against the drug have really become much more positive, and there are several states that have made it legal. It's not illegal in many states. And even in those states where it's still illegal, it's not being reinforced. It's not being, you know, people are not being caught and put in prison because of it. So drugs, illicit drugs, any kind of drug, the minute they become legal, easy to find, the rate goes up. I mean, unfortunately, that's what happened with alcohol. When the prohibition of alcohol, the rates of alcoholism in the States were 10 times lower. Minute alcohol was, you know, the lifting of the prohibition, you know, the rates started going up. Now, I'm not saying that we should make it, you know, that we should prohibit the use of alcohol. I'm just saying that that is a reality, you know. And we know it from epidemiologically from other countries where the drugs are very expensive, you know, that in poor countries, there are very few drug addicts. Mexico, for example, there's very few drug addicts like we used to have before. Okay. Now in Puerto Rico, we have the same laws as the US in terms of marijuana. Okay? We have the same opioid epidemic that you guys have. Except that right now, you don't have an epi study to show you what that has done to the prevalence of illicit drug use in Puerto Rico, in the States. You know, we hope that Bridget and Deborah publish it soon.
So, Glorisa, in order to be a disorder, should there be some impairment?
Oh yeah.
And so, I mean, occupational stability is one of the impairment. How would that impact the rate?
Yeah.
high.
Yeah. Remember, I am not talking about illicit drug use. I am talking about the disorder. The disorder is very different. You can have all kinds of use. You can have experimental use, which does absolutely nothing. You can have recreational use, which could be only when you get together with your friends. You could have abuse, you could have misuse, which is you use more than what you should for your health reasons, but you're still not addicted. And then you could have a disorder, which means you're already dependent on the drug, and it causes significant impairment in your functioning, either at school, if you're a teenager, at work, if you're an adult, at home, and in your community. So you have to meet a lot of criteria in order to get a 7.8% of the population meeting the criteria. Not using it. Using is 18% of use. We know that. It's almost a quarter of the population using any kind of drug. So the US has always have had higher rates of substance use disorders than we have in the past. I still don't know what is the illicit drug use rate for you. This one is substance use disorders. It includes alcohol. And I'm going to show you now, the alcohol rate. Okay? So I'll show you the alcohol rate. It's down here, okay? This, in 1987, we 0.2, this is what it is right now, but in 1987, you had 5% of last year. These are all last year disorders. It's not lifetime. Last year, we had 5% in 1984. Now we have 5.2. It didn't change over time. And as you can see, the big difference between the alcohol abuse for island versus U.S. Puerto Ricans, and the same with U.S. overall. All the substance use disorders, alcohol and illicit drugs, were much higher in Puerto Rico. But when you look at these are unadjusted rates, by the way. I haven't shown you any adjusted rates. And what I mean by adjusted rates means that we control for demographic characteristics. And since our demographic characteristics, are so different in terms of education and employment and all the risks all the demographics that put people at risk, we have to control for it because prevalences do change when you control. I've been showing to you only unadjusted. Okay, so unadjusted rates. Oops. Okay. How did this happen? Okay. The unadjusted rates, the main differences were in the substance use disorder. In the other disorders, you find differences in major depression, with the island having higher versus the US, social phobia. I'm not going to go into the anxieties because they're not too good, as I already told you before. But dysthymia, US Puerto Ricans 4.3, VS Island 2.3, and alcohol abuse differences also. When we adjust, we're controlling now for demographics. We find that in the regression analysis, we found higher prevalence rates in the US population of anxiety and depressive disorders as compared to the island. That we found exactly the same thing in 1987. You control, when before we had higher, you control, now we have, lower. Except for alcohol and drug use disorders. But again, I'm telling you, these other two studies, if we had an NCSR now, 2 years ago, another study, of psychiatric disorders in the States, I could cut my throat that is going to be like us, higher than us. The rates, particularly illicit drug use. I mean, you saw yesterday in CNN News what's going on with the opioid epidemic, right? people dying by the bunch, so many people dying. We still don't know what the prevalence is of opioid, drug disorders or of any kind of illicit drug use in the US, except for 12 or 13 years ago, what the rates had. And they had to be much higher now. Okay, so, we still have higher rates, and my estimation is because there are differences in the timing of the studies. And when we adjusted the comparisons between island and US Puerto Ricans, we showed higher rates of US Puerto Ricans on depressive and anxiety disorders, what we had expected, But the differences in prevalence rates disappeared when social support was entered into the model. That was the Model 3. That means that social support, contrary to what we had expected that social support and family support was going to be important in our population versus the other two populations. But it seems like it's important in every population. Go ahead.
Good question. Is there the criteria for what's a mainland Puerto Rican? Is it one who's been born here and stayed here, come from the island and stayed there a few years? What's the
Okay, that's a very good question. Would be another paper. This includes a very interesting paper, and I'm going to make available the data to whoever wants to do it, because I just don't have time to keep on, working with this data. But no, this is all U.S. Puerto Ricans. So there, in that bunch, you have Puerto Ricans who were born in Puerto Rico and migrated, and Puerto Ricans who were born in the US, So you have all the mix of Puerto Ricans. And obviously we know that those who are recently migrated have lower risk of psychiatric disorders than those who, but no, actually, no. I was telling you something that is not true. That is only true for Mexican Americans and other Latinos, but for Puerto Ricans, Maggie Alegría has published that island Puerto Ricans versus US, not island Puerto Ricans, no, US Puerto Ricans that were born in Puerto Rico versus US Puerto Ricans that were born in the States, there is no difference in risk of psychiatric disorders. Not the same, so that means that what is called the immigrant paradox, which means that those who are immigrants are at higher risk, but in reality are supposed to be at higher risk because they have so many more stressors, but in reality that's not what happens. The immigrants have lower risk than the populations that were born in the States, in great part because the population from where they come from is more healthy, in terms of psychiatric disorders. And I don't know if you guys know, but the comparisons of the US rates that NCSR did with other studies, WHO studies around the world, US population had highest rates for almost all psychiatric disorders, So that's why, in reality, when you compare, in other populations except us, but you have to remember we're US citizens, that you find that those who came from their place of origin, who were not born in the US, have lower rates, except for us. We don't have a difference. We are US citizens. We have been under the influence of the American culture for more than 100 years. So, okay. We hypothesize, this is our discussion, I already told you this. I'm not telling you anything different. So, rates of alcohol disorder haven't changed in 30 years. Now, you have to remember, our rates are high. These are last year rates. But we know from worldwide psychiatric epidemiology that any country that produces a drug like we do, we're big rum producers, is going to have high rates of consumption. High rates of consumption because cheap. If you produce something, you're going to get it everywhere. You can buy a rum, you can buy rum in a supermarket. You can buy rum in the pharmacy, rum everywhere, you know. And nobody asks you for your ID unless you're this big and you're not a midget, okay? So, it's true. So it's so available that whenever a drug is available, you know you're going to have high rates of consumption, high rates of disorder too, because one goes with the other. You cannot have high rates of something that is not available, okay? Not available because it's too expensive, not available because it causes you health conditions, whatever. So that hasn't changed. We drink a lot, you know, and we drink socially. Everybody drinks, you know. We give to our babies a little bit of, you know, beer to taste it. They go, I don't like it. Try finding out a parent here who gives beer to their baby. That doesn't happen, right? I mean, it's tasting, but not even tasting is appropriate here. So cultures do vary on their way of seeing, particularly with alcohol. It varies a lot. Okay. So we have our latest study on alcohol. We found no relationship between alcohol use and alcohol disorder and unemployment. That is completely out of the realm of what you find in the literature. Unemployed people in the US have much higher rates of alcohol disorder. It has nothing to do with Puerto Rico. You could be unemployed or out of the labor force, and it doesn't increase or decrease your risk. Go ahead.
That was my question.
Yeah.
It's about, you know, does the unemployment or the out of the workforce component
Nothing. Yeah, Raul Cayetano, I don't know if any of you who do psych epi know, you know, particularly alcohol. He's like the father of the psych epi in alcoholism, he and Bridget Grant. And he did a study with us just on alcohol patterns and alcohol disorder in the San Juan metropolitan area, and has published about 4 or 5 papers on the issue of patterns of alcohol use in the island, and also the relationship of alcohol disorders with different risk factors. And it doesn't work. I mean, unemployment has nothing to do with use of alcohol in the island. Okay? So let's see what else. Okay. US Puerto Ricans are a high-risk group, like I told you in the beginning, and that really showed. However, previous results of NLAS show higher rates of disorder of the US Puerto Ricans compared to any other Latino group, possibly due to greater perceived discrimination and downward, you know, social mobility, as we had hypothesized, you know. So the US population had higher rates of anxiety disorder than the island when you controlled for the demographic characteristics, and the US Puerto Rican had higher rates of depressive and anxiety disorders when we controlled. But what I thought was important, and we're going to be analyzing further to find out what's going on, is the fact that all 3 studies, social support was an important factor in resilience against psychiatric disorders. Okay? I think that's about it. I mean, I think I have explained all of this to you. So, what does the future have to do with this? And the future between the collaboration of the University of Puerto Rico with Drexel, that, of course, I love it because, you know, I'm going to keep working with Alex Ortega, who has been working with us for many years. And that is that we're going to use this study, as I told you in the beginning, to be able to examine in more detail, you know. And I didn't present to you here, I should have, you know, but we also gave PTSD in this study. And the reason I didn't show it, because in reality, what we used was this PCL, which is a symptom scale that you could end up making it, it's not part of the CD. It is part of the CD, but it doesn't have the algorithms to give you a PTSD disorder. So it gives you like high symptoms of PTSD. So we will be able to use the same scale that's called the PCL of PTSD symptomatology and all the others, and be able to then see how the hurricane affected the mental health of our population by exposure level, And of course, obviously, as you well know, with disasters, the poor, all over the world, the poor are always worse off than the rest. But when the disaster comes, they're even worster. That word doesn't exist, but they're really probably worst. Because they live in inundated areas, usually, which are the poor areas, where they can build their houses. Because they have, in Puerto Rico particularly, I don't know if any of you have gone to poor countries, but the houses are made out of wood, and they really have like a zinc roof that is blown, very fast. And the wood is shattered with winds of 155 winds per hour, like the Maria was the worst hurricane that has ever happened in our island, ever, in all our history. It was a tremendous disaster for us. We were out of electricity. There's still a third of the population without electricity 7.5 months later. Most of the population was without electricity from September 21 to December. So that's a lot of months without electricity, and a lot of people for the first 3 weeks were out of water and electricity. Water, can you imagine? A lot of people were incommunicated. The government was just not good enough in terms of providing the people with the most need with the services they needed. The U.S., Trump was just incredible. He threw paper at us. You saw it on TV, all of you. It was just like, I couldn't believe it, when I was seeing it. So it has been like not only the worst disaster we have ever had, but the worst recuperation help that we have ever gotten from a disaster. So my expectation is that we're going to have a lot of people with PTSD symptomatology, very high rates of psychiatric disorder, particularly PTSD, depression, and anxiety. And we are going to have a much longer period of recuperation. In most disasters, within 6 months to a year, the people who develop a disorder or develop high symptomatologies are okay after, But in this case, the aftermath has been so long, that it's not going to be 6 months or a year after. So we will have the data. We're going to get that grant. Okay.
Hi, thank you. I was just wondering how complex that measure of social support is going to be now after, well, considering during the recovery process and currently, and just thinking about conceptualizing social support. For me, I feel like on the island, I'm 25 as well, and I feel like, Don Pablo coming from Pueblo to help somebody might be a different concept than strangers coming with, some kind of, building materials or political support where you feel like you're getting it from your local government. Are you thinking about the different levels of that kind of support?
Alex, answer that question.
We are looking at, the focus of this proposal beyond both the local and federal government response to the hurricane, both actual and perceived, as well as exposure to the hurricane, which includes things like, experience of violence and the trauma and the not having water and electricity and the impact and access to care. And actually a separate study, which Dr. Harris submitted last week, he's looking at the behavioral health system response after the hurricane.
it's different.
Informality of the type of support that.
Yeah, we definitely have to make a much bigger support mechanism questionnaire, and maybe ask, the people who did the study with Katrina what they did in terms of that kind of community support, which of course that's one of the good things about us, is that we help each other in the time of need, I mean, that's true of every population, I have to say, I remember when you had, that big scare in New York, of terrorism, and the Boston, terrorism, the population just got united, helping each other, a lot. So, I mean, whenever there is that kind of acute stressor, I mean, the good thing about humans comes out, Obviously, in the aftermath, not all the good things come out, We unfortunately don't have any statistics of what happened for those 2 months in which everything was dark. But we all know then when communities are completely dark, criminality goes up, And we don't know how it went up, but I am almost sure, people were deadly afraid of coming out of their homes, And if you've been driving, there is a lot of traffic accidents also. So, I mean, there were a lot of things that there are no statistics for that I'm sure we'll be able to capture in this study, Go ahead.
In the months prior to Hurricane Maria, there were a lot of discussions around, in fact, the Congress was debating should they bail out Puerto Rico. And I'm curious, how much did that impact the man on the street?
Very much so. I think that's why it's so important to measure this, because there was a lot of anger, and everybody was talking about racial and ethnic discrimination against us, because it is obvious if you send all this help for, the hurricane in Texas, and we were seeing it in the news, all these trucks coming in massively with all these, relief, and then we get a hurricane that is like 10 million times worse. And our population, because of its poverty in general, is devastated, And you could see from an airplane the devastation, and there are photos of, it's almost like it was almost, a friend of mine said that when she went out in her car, during the day, it was almost like if somebody had come with a torch and burned all the trees and all the wooden houses, and devastated with that huge torch, burned the whole island. And so that is very different from what happened in Texas, And then after the hurricane, we had torrential rains that made things even worse. For 2 weeks, raining every day. I mean, I'm watching it, you two guys, because you're Puerto Rican too, you knew what was going on. It was really bad.
Actually, I didn't really mean in terms of what was happening in Texas prior. A year before with the bankruptcy. That's what I really was referring to.
Well, I let you know that in top of that, we had this trauma, but the hurricane brought one good thing. Besides what they were talking about, the community help, it brought a lot of money. It's bringing a lot of money to the island. And we were really bankrupt. But now, a lot of millions of dollars have been, sent to the island for reconstruction. So I don't know if you must have read in the news, $300 million for this, $265 million for that. So all of a sudden we get this influx of money, that is supposedly to go for the, restoration of the island. And as in every country where every disaster, where that big part of that is going to stay in corruption, we know that. Don't you think it's only Puerto Rico? You look at Katrina, the same thing happened. You look at, Taiwan, the same thing happened. The government stays, the cronies of the government stays with part of the relief money everywhere. So we're not different. So it's good. Go ahead.
What are the indices that you track, mental health indices? Are there any in particular that correlate with suicide rates? And I was curious if there's been an increase in suicide following the hurricane.
Well, that's a very good question because there's been a debate in the island, okay? So the New York Times, I don't know if you had a chance of reading it, came out sometime about a couple of months ago with an article in Puerto Rico showing statistics of a year before. Between 2017, the rates of suicide, that were published in the island, and then the 2018 suicide rates of the island. And there was a dramatic increase. And the article said that statisticians had analyzed the data and showed that the difference was at the 0.01 level of significance, showing that it couldn't have been at random, that it had to be due to a major stressor, and what other major stressor than Maria, So they concluded that it must have been due to Maria, the dramatic increase in suicide rates. But then the government, about 3 weeks later, came out with an article in the Puerto Rican, Nuevo Dia, Puerto Rican paper, showing the rates of suicide for the last 10 years in the island. And the rate of the 2018 was not different from other years in the island. So they kept saying that they did not think that the suicide rate was, due, that the increase was due to the, but I have not gone to look at myself that data. And you know what? I don't trust this because I have seen what has happened in the island after, this hurricane, and how, the government distorts the bad news and distorts that what's happening to some of the population. So I'm not sure. I would have to go and check it myself. I tend to think that that the rates, this big difference in rates, the New York Times was right. And remember what I said to you before in the beginning, or I don't know if it was to you, but I was telling to some students that when when something is an epidemic, when somebody in your small circle has the illness. Well, you know what? Somebody in my circle committed suicide after, the hurricane. And we are convinced, that was due in great part to the stressors associated to the aftermath of the hurricane. And I have a very small circle. So, yes, I agree with the New York Times.
We'll be able to look at suicide ideation in this
And attempts. And attempts. Yeah.
Sort of a similar question, though not related to suicide. One of the things that I read, maybe in the months or weeks after the hurricane, was that I think it was speculative. It was like a speculative article that people might leave the island because the hurricane was so bad and the response was so stagnant that conditions were sort of untenable. So people were going to move to Miami, to New York. I'm just wondering if you've seen that kind of out-migration.
Oh, yeah, we have.
And what the implications are, not just for health on the island, because these people with means are leaving, but also for those populations of Puerto Ricans that exist in like Miami and New York, where they're migrating to.
Well, there is definitely, has happened already, and we know it, 6% of the population moved to the States. 6% of our population is a big, big number, okay? In in just few months, after the hurricane, we lost 6% of our population. So I am now doing this study of this cohort that we have been studying since they were kids, and we now know from this cohort in Puerto Rico is around 1,300, young adults, which are usually the ones that leave the fastest, And out of area, meaning that they left the island, we have now 18.6% of our cohort leave. It's a really big number. Now, before, because of the economic conditions, we had a big percentage. We used to have, it coincided. We used to have a big percentage leaving, and when we added the percentage that was leaving before the hurricane with the ones that were coming after the hurricane it was 6%. Before we had around 11 or 12% of the population leaving, just because of the economic conditions.
Are you going to follow up with those people? Is there a way to do that?
No, this is a different cohort completely. This is a representative sample of the island, and this is a study that we did of a representative sample of children, 5 to 13, on the first wave in 2000, and we have been following them in Puerto Rico and in the Bronx. And we've been following them over time, and now they're young adults. It's a completely different study. Yeah, it's completely different.
We have one more question.
Oh, actually, you can tell Brenda and I work together because he stole my question, but I actually was thinking about that if I understand correctly, for your new project, you're planning to follow up with the same people who took the survey?
Yeah, and so there are going to be people who are not going to be there.
Right, and I think that would be important to think about.
Yes.
How you graph the study.
The good thing about this is we can do telephone interviews if we're able to locate them.
With some of them, we can't give them the full CD. We can't give the symptoms. We'll figure it out. But
We have given the full CD, we just don't give it in one sitting, and you have to pay them more. But we have given the full CD in, 2 or 3 sittings.
Complicated, but the second part of my question or comment was that I think it's really important that you look at the impact that the hurricane has had on the Puerto Rican population here, whether they came as a result of the event or if they were already living. There are many families who are taking relatives who have moved, so if they were already strained before, being, responsible for additional relatives that might be in a temporary or perhaps, more permanent situation at some point here. And also that feeling of discrimination, of, being second-class citizens that, are hearing from their family members in the island, of, even if they weren't there, all the things that are happening to their loved ones over there. So I can tell that that's going to probably have an impact.
What we can do, that's a different story, a different study, and it should be done. But what we can do is make the budget for, being able to do the telephone interviews for those outside of the island, which could be 6% of the sample at this point.
right now, we're just figuring out how much, what using a subsample, like just doing random of the current sample.
How many are still there?
How many we can still contact, how many moved away? Can we still contact the ones that moved away?
But I imagine that it's going to keep constant, which was incredible for us to find out that there was an article in the newspaper, because of course nobody else is doing this kind of study yet, that showed 6% of the population moving to the States after the hurricane. And then we find the same with our cohort of 1,000. So I wouldn't be surprised if the same happens with this 3,000 people, that 6% have left. So it seems like it's a stable percentage. And we might find when we analyze the data that there are usually the younger ones, or the sick. But usually the elderly left the island because they didn't have any kind of facilities and their kids were here in the States, they came back. Most of them are back. They just don't want to leave in the States, you know. Older people don't want to leave their country. It's only the young ones. So mostly what we will think, if they're still here, is that they're going to be the young ones.
Thank you very much.
Okay.